this is the panel discussion about home therapies. The format is like we have three wonderful presenters and speakers and experts, and Dr. Sharma and myself, we will be your kind of moderators. So we will, if you have questions, then we will help you. We'd like it to be interactive, so the way we have a 45-minute session. We ask our presenters to give 7 to 10 minutes, their case, and then we will have some QA. So please, if a question comes to you, either if you write on a piece of paper, that's sometimes easy, and hand it over to me or Dr. Sharma, and we will represent you, or you can ask yourself. So you have already heard the wonderful introduction of Dr. Bett. I would go ahead and introduce Dr. Surju Patel, who's sitting next to me. I have to tell you something, that I've known Dr. Patel for over half a decade now, maybe longer. So I'm like jealous that he always looks young, and he continues to look young. He has the best hairstyle, right? Dr. Patel, he completed his med school at St. Matthew's University and then residency in Temple Memorial in Johnstown. He was trained at Penn State for his nephrology fellowship and has been in Harrisburg since then. He is native of Harrisburg, so this region is very familiar with him. So we are happy that he did not, after completion of fellowship, he did not move too far. Dr. Miller, all of you know Dr. Miller. In this room, there are many, including myself, Dr. Basit, Dr. Patel, Dr. Geramani, who else? So we are very fortunate and grateful that Dr. Miller has been our program director. So he actually trained all of us. He's a master educator. In my life, there are few people in that top list, and he's always on the top as the master educator. I know Dr. Basit, actually Dr. Khan was here too. I don't see him. So all of us are Dr. Miller's trainees.
That means if they do well, it's their fault. If they do poorly, it's my fault.
Dr. Miller did his med school at Boston University School of Medicine and his residency at Naval Medical Center in Portsmouth. And his nephrology fellowship was University of California in San Diego. He is truly a master educator, and when he speaks, everybody likes to listen and hear. So without further, I would request Dr. Patel to come in. So with the time, we said 10 minutes, but I requested him to go through his slides 7 to 10 minutes.
Well, thank you for having me here. A lot of you guys I know. When Dr. Farooq asked me to do this presentation, it's more about how do you get patients to get interested in home dialysis, and what does it mean to go on home dialysis. So I started this presentation with a case, and then we'll go more depth into the case. So we have our patient Bill. He's a 54-year-old male with a past medical history of hypertension, type 2 diabetes, diabetic retinopathy, who has developed CKD related to uncontrolled diabetes and recently had progressed to CKD stage 4. The patient has a busy work schedule and works 6 to 7 days a week, which has prevented him to follow through with his PCP and his nephrologist. His A1C was 10 several years ago, and now it's down to 7.5. His home medications are insulin, lisinopril, Farxiga, simvastatin, aspirin. He lives with his wife and 2 children, and he also has a dog and a cat. He sees his nephrologist for a follow-up, and his creatinine is 3.4. His A1C is 7.5, and his potassium is 5.3 with a phosphorus of 5.5. He has lower extremity swelling and does not follow a low-salt diet. His nephrologist initiated the conversation of dialysis and explained the different modalities of dialysis. And patient left the visit overwhelmed with many questions. So we have quite a bit of patients or patients themselves here have probably gone through this. So thoughts and questions that are going through the patient's head: how am I going to work? I'm too young to be on dialysis, and will I survive this? What is dialysis? How often am I going to have to do dialysis? And I do not want to feel like my neighbor who goes to dialysis 3 times a week and doesn't feel well after his treatment. So when we, in our practice with nephrology associates, we do, and this is based off of our perspective of how we initiate the conversation for dialysis. So we try to do it early on to start preparing our patients early in the CKD stage 4 stage. We like to discuss the different modalities of dialysis, like PD, home hemodialysis, and in-center dialysis. Your initial conversation, you don't want to try to overwhelm the patient during the first visit. It's a lot of information to take in. We like to do things step by step. And then we schedule an education visit with our practice. And I have to give our credit to our nurse practitioners in our practice. Christy is one of them, who are the backbone of this education. They really take the effort and time to discuss what it means to be on dialysis. So a typical dialysis education for what we do is we schedule a 45 to 60-minute visit. The visits are conducted like every 1 to 2 months, but it alternates with our providers, like the nephrologists, so that they go and do the education visit, and then they come back, and then they have some questions for us. The topics we discuss is just not dialysis, because it involves all different aspects of dialysis or their chronic kidney disease. So we do discuss the different modalities. We discuss transplant, we discuss hypertension, diet, depression. And that's one thing that, sometimes we forget to discuss with our patients, depression. So we do try to discuss that at our dialysis education. And then we do a one-to-one. The topics are individualized based off of the needs of the patient. And we go over the topic with verbal discussion and a written discussion. So we do have a binder where we have our education material. We give it, to our patients to look over. And then during the COVID pandemic, we didn't stop doing the dialysis education. We did have to do telehealth. So we further, if our patients still need more support, we do make a referral to the peer mentoring program, which is the patient, family, and partner program through the Kidney Foundation. And this kind of gives the patient an idea what other patients are going through. I see one of my peer mentors here that does a good job in being a support system for the patients. So the visit also helps to establish relationship with our physician extenders for better transition to dialysis, allows for more time to discuss AV fistula, PD catheter placement, and patients are better aware of their diagnosis and make better decisions about dialysis. Also, the patients takes more responsibility of their health, and it helps slow progression of CKD in some patients. And we've seen this, that they are more aware of their diet, more aware of what their blood pressure is doing. They're more aware of what responsibilities they have. And a lot of the times it may slow down the dialysis by a year or so. So the home therapy pre-education, so how PD and home hemo works. PD most likely is daily with home hemodialysis 4 to 6 days a week. There's different types of PD, CAPD and CCPD. CCPD where you use the cycler. You have more flexibility in traveling. You have self-care and autonomy, better fluid and blood pressure control. Electrolytes are well controlled and able to maintain your residual renal function, which is very important in longevity of yourself. So the important to discuss expectations. I do like to, let our patients know that, we want you to be compliant with the prescriptions, managing medications, monthly labs, and recording the treatment logs. If choosing PD, it's important to discuss what the backup plan is if the PD doesn't work. So as you lose your residual renal function, you may need to consider other modalities like home hemo. So the plan after education, we do like to assess what our patients have learned and what we need to work more on. So we do assess the understanding of the topic, whether it's like a crossword puzzle or asking the patients questions. Patient may want to see what a dialysis machine is or a home dialysis machine is. So we do have them take a tour of the dialysis unit or the machine itself. And sometimes I do make a referral for AV fistula, even though they're going on PD, so that you have that backup access in case the PD doesn't work. And then patients who need to start PD, but they're just not ready yet, we can always do a buried PD catheter. So the PD catheter is placed without an exit site, and it's placed a couple of months in advance of starting PD. And then, of course, transplant referral. And I think it's important to talk about hospice and palliative if someone does not want to pursue dialysis. Okay. So Bill chooses to proceed with PD. However, he is concerned if he even qualifies because his BMI is greater than 35. He had abdominal surgeries and had an ostomy. Someone also told him that the risk of survival is higher with HD than PD. And he also had animals in the house. So barriers for peritoneal dialysis. So abdominal surgeries, surgeons can lyse adhesions and do laparoscopic procedures to get them to the point for PD. So the ostomies, so that's a question I get quite a bit about the colostomies. So it's individualized. There's a risk of peritonitis in certain populations, and especially in inflammatory bowel disease. And you may consider a pre-sternal catheter. PD catheter doesn't always have to be down here. It can come up here. So that is an option. And the survival risk of PD versus HD after 5 years is 41.6 and 51.5 respectively. And, someone who is with obesity and PD, better survival is first 2 years of PD and less hospitalization. You can have animals as long as they stay away from the PD catheter site, and recommend the animals sleep in a separate room. So Bill chooses to pursue peritoneal dialysis, and his adequacy has been trending downward, and his residual urine output has been dropping. Bill's nephrologist discusses home hemodialysis, and he is not sure about it, and patient's wife feels it may be overwhelming. So transition from PD to home hemo. Start the conversations early. Identify patients who will fail PD early. And the biggest barrier is the cannulation and trying to at least get the AV fistula placed before starting the PD or before starting home hemodialysis. Start teaching cannulation early, emphasize on autonomy, and we're dealing with a different world right now with the pandemic, and as you can see, there's lack of staffing throughout the country in dialysis units, and so if we want to get some of our patients to dialysis a little bit quicker, home dialysis is something that is the other option. And then familiarize patient with the equipment while on PD.
All right, so I'm here to talk about the transitional care unit and the role that the transitional care unit helps with pipelining into the home therapies program, whether it's AD or HHD. So first, we'll describe what a transitional care unit is. It is a dedicated space that's created to cater to the most vulnerable time in an ESRD patient's lifetime, the moment that they start dialysis. What is their journey going to be like? We know that about half the patients crash into dialysis without having a good start. They may have been diagnosed with chronic kidney disease, but then had a rapid progression in their kidney function and ended up on dialysis quicker than imagined. We know about a quarter of patients crash into dialysis without ever being diagnosed with chronic kidney disease. So it's kind of like brand new to them. They had no idea. A sizable portion, like I mentioned, irrespective of their pre-dialysis nephrology care, may not have access to adequate preparation because of that sudden loss in GFR. And the cost of these crashes are enormous. About $53,000 during that first year in dialysis is the healthcare cost for crashing into dialysis. And we know that 74% of patients start dialysis without a preferred vascular access in place, mostly because they either did not have enough education or enough time to get an access placed. Why do we care? This graph here is from the USRDS, and it looks at different countries and the mortality across different countries within the first 120 days, which is the first gray bar, and then moving along through the year of dialysis. And it shows that the highest mortality for any patient, no matter what country they're in, US is the second graph, but we have France, UK, Great Britain. All of those countries, no matter what their health system is, the highest mortality is in the first 120 days. And that's when we want to make the biggest impact. So, like I mentioned, most patients start suboptimally, and some of them may have had education that he had provided, but months ahead, and they don't remember most of the details that they learned at that point. Or maybe they're not sure about the choice that they made. Maybe they decided, I don't want to do peritoneal dialysis because I have too many barriers, and I'm just going to go straight to HD because it's the easiest choice. Some had that rapid loss in GFR, but all patients, even if they had all the education in the world, once the rubber hits the road, that's when they really start to absorb and understand what their world is going to be like. So it's a very traumatic time in the patient's life, and we want to try and make that transition as smooth as we can. So we want to impact those first 90 days so that we can decrease the risk of death. We can decrease the risk of hospitalization. We can increase their access and make sure that they have the most optimal access for them and that their risk of infection is low. And those things are the things that increase the mortality rate within those first 120 days. We want to decrease the cost to healthcare as healthcare partners. And we also want to decrease mortality. So that is the role of the transitional care unit, is to try and transition these patients from chronic kidney disease to their world of dialysis. Historically, actually, the transitional care unit was first established, or the first transitional care unit in the United States was established in Arizona, in the Northwestern Kidney Centers in 1981. They called it a stabilization program. It was a 2-month program that emphasized modality, they emphasized diet education, and patient rehabilitation with transitioning safely to home dialysis. It was a physically separate unit, and they had a very high staff-to-patient ratio. And they had a very close collaboration with the home training programs. The unit staff members had to be highly motivated to teach. They picked staff that were teachers so that the patients can get the education that they need. Within that first year, they had 93 patients, and actually 62% of those patients chose a home modality. 24% chose what's called self-in-center program. We don't have those, I don't think, anywhere. But what that is it's a space where the patients show up and get a dialysis treatment, but the patient is doing it all themselves. They're not doing it at their home, but they're doing it at the center. So it's almost like a patient-assisted program. And then 10% chose in-center dialysis. So it was a very successful program. And I think from a funding standpoint, it didn't last very long. And so it kind of fell to the wayside. So a typical TCU structure or a transitional care unit structure is a 3 to 4 week program. It can be established in any center. It can be a standalone, or there are some models where they just take a pod and call that the transitional care program. And it's 3 to 4 treatments a week. Ideally, honestly, in the beginning of a patient's dialysis life, I think 4 treatments are better than 3 treatments, because it eliminates what we call the 2-day gap, that killer gap. When patients have 2 days off, that's when the highest mortality in patient care happens. But because of staffing issues, our program is a 3-time-a-week program. And we focus on extensive education. And there are goals of each week that the patients and the staff have so that the patients go through this program. Initially, we focus more on psychosocial, adapting to dialysis. They usually uremic. They're not able to comprehend too many things all at once. They're just overwhelmed. And I think the role there is mostly just to stabilize them and provide psychosocial support. And then we move on to education, probably the second week, modality education also that second week as well, and transplant referrals as well as access if they don't have one. Again, we have a dedicated space. The reason it works better as a dedicated space is because they don't get lost in center. I say that because they kind of see patients coming in and out, and they're like, that's kind of normal. I'm just going to stick with that. I'm just going to move over to that chair and do my dialysis over there moving forward. You need to have staff that are flexible, and you need to have staff who are able to deal with high volume, because they're only there for 3 to 4 weeks. They're high acuity. They're high acuity, and they're out in 4 weeks. So that transition, you need to have staff that are able to do that. And lastly, you have to have buy-in from the physicians. You have to have physicians and APPs who buy into the program, who are going to refer the patients to your program so that you can provide that modality. And you need support from your dialysis vendor, whoever that is, to help you establish that unit. We talked about clinical stabilization. Okay, we talked about clinical stabilization that first week, and then focusing on education, emotional and psychological support. And it is a welcoming environment. Think about it. Most of the time when patients start dialysis, they're stuck on that Tuesday, Thursday, Saturday shift, third shift. There's usually skeleton staff. There's no one to tell them welcome. It's a pretty hard time to be on dialysis. So this gives you that more welcoming. You have more one-on-one with the nurse. You have one-on-one with the social worker. You have one-on-one with the dietitian. So it allows them to be able to be met at that vulnerable time. And it allows us to streamline access appointment and transplant referrals. My goal for the patients by the time they get to their 3-week mark is they've already determined what modality they're going to be in, at least have an idea. We're not pushing them, but we want to make sure that they have the education that they need, that their transplant referrals are already in place if they didn't have that pre-dialysis, and that they have their access appointments already established. Our local data, we've had about 120 patients to date. About 36 of those have chosen peritoneal dialysis. We've had 7 choose home hemodialysis, and that's about a 35% home penetrance rate just from this program. Obviously, we do not, if patients have already chosen PD as a modality from their pre-dialysis education, they go straight to PD. We don't kind of bring them to TCU to prove a point. We usually get those patients who didn't know, weren't sure. And we've also had some patients who are pretty sure they didn't want to do home therapies, but ended up doing home therapies after they finished that program. We want to empower the patient. So our goal is to empower the patient. We want to make sure that the patient and the physician choose the modality that fits the patient the best. So one of the things about having buy-in from the physicians is that they're comfortable that you're not pushing their patients into a modality they don't think is appropriate for them. It eliminates the bias of, those disparities in home therapies. You have, not enough Black patients being referred to home therapies because we have the perceived notion of the barriers that they may have at home. So when they're there for 3 to 4 weeks, we're able to kind of streamline them to that. We improve transplant referrals. We decrease hospitalization rates and mortality, and there's definitely decreased latency in access placement. 12% lower CVC rate and 27% lower missed treatment rate. So even if they don't choose a home modality and they go in center, some data that shows that they do become better dialysis patients as far as coming to dialysis and not missing treatments. There are some challenges. Some of the challenges are throughput and having a consistent census. Sometimes when it rains and pours, and sometimes there are no patients. So you want the patients that come in for this program are usually new starts. So it's not someone who's switching modalities most of the time. And then there are some bottlenecks that are related to modality choice. So if they don't decide to do peritoneal dialysis early in their education, and maybe they decide that at week 3, now you still have to go get them the PD catheter, and you have to hopefully maybe wait till the PD catheter is ready to use. What do you do with them when they're done with that 3 to 4 week program? Do you get them in center? Do you just keep them there until they're ready to do PD? Those are some of the challenges that we have. Ideally, I like to keep them until they can transition to a home modality so they don't get quote unquote lost in center. So we're still working through those challenges. It's a little tougher with staffing challenges, especially now that there are no spots in the county. We've become like the sponge that kind of takes the patients out of the hospital, at least for the first 3 to 4 weeks. And then they're kind of, again, another bottleneck. We have nowhere to send them after the 3 to 4 weeks. So currently we have a patient who's been there for 8 weeks where we're waiting for dialysis spot to open up. We're hoping they maybe could choose a home modality, but it's not the right time for them. So
The clock there says hello. So I have 10 minutes to change your mind about something, and I have 10 minutes to make you excited about something. Now, I realize it's the middle of the afternoon, you're under-caffeinated, I'm looking around, there is like one person with caffeine, maybe 2 in front of them, and that's a difficult 3. That's a difficult thing. So let me tell you a story. We know across the country that 90% of patients end up on in-center hemo, right? We know 10 are going to home. Majority of those are PD. Growing fraction are home HD. But if we asked us, what would we pick? For me, I would pick PD as a bridge to transplant. So why do we have that disparity between what we're doing for our patients and what we're feeling for ourselves? And it's multifactorial. That's a whole other talk. So I have 10 minutes to do this. Next year, I'm going to bribe the committee so I get longer time to entertain you or to prove the point. That's a whole other talk. So how do we get people doing the right kind of dialysis? We try to do the right thing. We try to do pre-ESRD education. I like TCU. I don't want my patients to have to go to TCU, right? I wanted to pick home and just bypass it entirely. But we've seen these patients, right? We've seen patients who they have CKD4, they're creeping along, you send them to education, and they choose to get listed, and they choose to do, let's say, PD. And they're doing okay until they're not. Because then they have an event which leads them to the ER, likely admission, and they need urgent start. And what do they get? We've talked up PD. I tell my patients, I want my biases up front. I am really biased towards PD. I want my patients to get PD. I will twist your arm for PD. And we've done all this preparation, and they end up with a tunnel catheter. They're on HD. They go to the unit, and they sort of linger in the unit waiting for the referral to surgery to get the catheter placed. And then how long do you wait? Once a PD catheter is in, how long do you not touch it? This is the interactive part that you were promised. Couple weeks, right? You just don't touch it. You flush it out of the OR, you bandage it, you don't touch it, then the PD nurse looks at it, and then at the 2-week point, you have the PD nurse able to do parallel therapy and training, right? Could we do that better? My argument's yes, and there are people who agree with this. I didn't come up with this idea, I just pass it on. I get to be the evangelist for it, not the one who thought it up. What happens if we are able to take patients and start them on PD in 24 to 48 hours of hitting the hospital or the clinic? Now, I know what you're thinking, right? There's a couple things you're thinking. This is boring, and it's the afternoon. No, the second thing is I can't start a patient on PD in 2 days, right? They're going to have leak. We've all been taught that there's leak, and you need to let that catheter set unmolested under a bandage for 2 weeks to do that. Now, there are patients for whom starting PD quickly wouldn't be appropriate. People with refractory hyperkalemia or symptomatic uremia, so pericarditis, horrible volume overload that you're not going to fix. So those are the emergent cases, and I'm not trying to convince you otherwise for them. But for the urgent starts, imagine if you could have an interventionalist, and that's the word I'll use to say interventional nephrology, radiology, or surgery, to place a catheter, a PD catheter, and then to be able to start doing therapy at the bedside or in clinic where you're getting a reduced prescription under nurse supervision, waiting for the catheter to heal up fully and waiting for the training to finish. And I'll tell you what, if you do that, you are going to shave weeks off that patient being able to start dialysis and then be at home to do it. And hopefully, again, I'm biased, shaving off patients who are then lost with a tunneled catheter out to get HD. Now, there are barriers to this, right? So one, we can't start patients who are, hyperkalemic or their BUN's 200, right? Can't do that. For the patients then who are good candidates, we need a couple of things. One, we need interventionalists who are able and willing to place a catheter within 24 to 48 hours. And number two, we need to have staff in the hospital or the clinic who are able to take care of that catheter, and part of that reflects back to the surgeon. They want to know that their creation, their baby, is being taken care of. So it works both ways there. The nurses take care of the patient, the nurses take care of the surgeon. So we have nurses who are able to do that, and that's not maybe the standard PD nurse because this isn't standard PD. We need to have buy-in from the people who write the checks, which aren't us. We need rooms, right? So if we're doing this in-house, then the patient has a room we can do at bedside if we have the nurses. If we're doing it in our clinics, though, we're going to have to double our PD space because we got a room to do training. We got a room to do training for the non-crash starts. We're going to have a second room, second nurse to be able to handle the acute starts, the urgent start PD patients. But if you're able to overcome those challenges, we can take patients, get a catheter in them, and start PD as their urgent modality and not rely on a catheter. So the third thing you're thinking is, but Dr. Miller, people have told me from when I was this tall that you can't use a catheter that quickly because of leak. People have looked at this. Now, the data behind urgent start are small but growing. We know that this can be done. We need more data on it, but the data that are there are really encouraging data. There was a Cochrane review like 2 years ago now that took a pooled bunch of studies, smaller studies, and found that yes, if you have an acute start patient, you are about 3-point-something% more, or 3-point-something more times more likely to have a leak. But guess what? The outcomes for that leak are not clinically significant. And interestingly, another study looked to see standard start versus urgent start PD and urgent start PD versus urgent start HD. And you know what? There was no increased risk of infection. There was no increased risk of catheter loss, catheter complication, or modality dropout. That seems amazing because when I was a fellow, I was always told, you do this for 2 weeks. You don't touch the catheter, let those two cuffs heal in, let the tunnel scar down. So yeah, there is a chance of leaking. It's handleable, it's manageable, and the data show that we can start this. Now, the PD regimen does not look normal. Anybody ever do urgent start PD or have any experience with it? Yeah. You want to shout out what your starting prescription might look like? No pressure. I think we stole the mic. So yeah, there's none over there. We can take that one.
This is important. I want to do a procedure. On my way. Because I want to hear.
Yeah.
Thank you for this.
For all those of you watching at home, this will be useful, right? This is a good question. If you're not watching at home, it's all right too.
There we go.
Hello?
Yeah.
laying completely flat as possible in a dialysis chair, usually guided a lot by the surgeons. Some have told me flush 200 in, let it sit for 5 minutes, let it come out. Other go for 500, just depends.
Okay.
If they're urgent start, you're going right for green solution.
Okay.
Training usually starts within 48 hours.
Yeah. And as long as the patient's able to handle the training at that
Absolutely.
point, or
Right.
until they're clear.
Right.
Somebody else had a different experience or an additional one, or no? You waved off, that's okay. So the usual prescription looks different. The average dwells are about 1,000 plus or minus 250, and based on body size. This is recumbent, and if they do stand up, they're getting up. You got to drain them, because what we're trying to do is to create the lowest abdominal pressure possible. And you're doing maybe over 6 hours, maybe 4 to 6 exchanges. And while this is happening, the nurse can do training after the first couple of days. We know that it can be done. There are centers doing it. We have to convince people, all y'all, it's plural, all y'all, all of you folks, if you're excited enough about it, if you're passionate enough about it, can start thinking about, how do you make this a thing? How do you actualize it? How do you get buy-in from the administrators, the hospital, us, the physicians? That amazing resource. You think that hemodialysis nurses don't grow on trees. PD nurses are even more rare. We're lucky. We have like the best PD nurse in the world, right? I think Gail's still there. Gail's not here right now. She's not paying me to say that. So you can tell her I said that, though. Yes, thank you. So if you have the right substrate, the right people to do it, the right space, people writing the checks, able to do it, we can help convert that 90%, 10% disparity of home versus in-center to more home, and do it by not letting patients get trapped by the undertow of urgent start HD with a tunnel catheter. So does it work? Yeah. Can you be excited about it? Yeah, I hope so. Am I the most excited person in the room about this right now? Probably. But if somebody else is able to get that critical mass started and be excited about it, then we did something right today. Yeah, that was about 10 minutes, right?
Excellent.
Not bad. That's all I got.
I wanted to thank Dr. Patel, Dr. Bett, and Dr. Miller for their presentations. So the goal of this talk was to think of innovative ways to increase home therapies in our patients. And so we were presented with kind of 3 different ways that different practices are using to increase their home population. We're running a bit behind time, but I just wanted to take any other questions that people had about any of the speakers' talks for 5 minutes or so.
I just have a question. So when you plan this and we get the buy-in and the money for PD, you have a data person that's going to be following this, because we always follow the money. You get the money based on the numbers. So, I mean, it sounds really good. So how do we do this going forward and make certain that we have the data to show funders? Because honestly, cost-benefit analysis, we got to show them the money, show them that it works. We know that it's good for patients, but at the end of the day, people want to know, is it good for the bottom line? How do we do that?
Yeah, data, right? More data are good data. I have no secret solution for that. And I think we have to be the advocates for making sure that we're doing the right thing to the patient, despite or in spite of the money. Because if we start doing it, what are we being able to do by keeping people off a catheter? And if we can show the data, which already have been shown, that urgent start PD have fewer infections than urgent start HD, just follow the data and we can show. We have the articles that show the statistics. I'm not a business person, but we know the results of the studies. So it should be showable.
Thank you.
This isn't working, is it?
So the federal government aims for a goal of 80% home therapies and renal transplants by 2025, which is a lofty and some argue unattainable goal. But we are moving towards that goal. I wanted each of your opinions about what you see some of the barriers in your real life, in your real practice life, in getting people to home therapies. I'll start with you.
So I think once they start in center, it's very difficult to get them to home PD or home hemo. So I think we need to start from the beginning and try to change the, try to push for home and PD. And then the second thing I've noticed is if PD fails, it seems like majority of the patients end up on in-center. But we forget about the home hemodialysis, which I think that transition is very important. To answer your question about, I think we need more manpower. As you can see, we have in the inpatient and outpatient, PD goes well as good as your nurses. So if you don't have enough nurses and if you don't have the manpower, it's going to be very difficult to attain this. So we have to start with our dialysis vendors, try to push them to try to create these programs so that we can get to that point.
Thank you, Dr. Sharma, for that question. There are definitely a lot of barriers. Some of them are perceived barriers that can be overcome right at the beginning of that dialysis life. A lot of times, the path of least resistance is get a catheter and just start dialysis. That's the path of least resistance for the nephrologist. It's the path of least resistance for the patient, but it's not the best choice. And so sometimes to get good outcomes, you need to do the work. And so I burden it on us, the educators, to be strong advocates and to not to say that you don't want to give the patient a choice, but tell them that this is the choice that you would, that will be best for you, because the patients at that point don't know. They don't know the benefit, and they kind of know Joe across the street who goes to dialysis, and they just kind of take that. The other thing that I think that we can hopefully, with this American Health Initiative that created these goals that seem to be lofty, I think some support, monetary support, because right now these home modalities are all self-managed, meaning there is no assistance from, there's no home assistance. And some patients could really use a little bit of assistance in their home, whether it's peritoneal dialysis or home hemodialysis. And that would still leave them off of the in-center dialysis and still get the good outcomes. It doesn't have to be 24-hour care, but are there programs where we could have a patient care tech or a nurse that kind of maybe goes in and helps them set up? Maybe they're not physically able to do that at the beginning of their dialysis life because they're so sick. So some of those are the barriers that we can maybe look into from a health advocacy to see if we can have more assistance for some patients in a home-assisted program.
I think Health Canada does that. They have some provinces where they have a nurse come out in the evening and a nurse come out in the morning, and they go between houses to actually do nurse-assisted PD. To answer the question, I'm going to put my educator hat on for a second, but not patient education, but fellow education. One of the things I tell all my fellows and all the applicants, it is application season after all, is that I want my fellows to leave the program not just being able to be competent at PD or home hemo, but to actually be enthusiastic about it. The only way we're going to be able to create a future situation and a future workforce that is pro-home therapy is to create people who are pro-home therapy. So my job is to create nephrologists who are pro-home therapy. And I imagine that then every of our graduates out there are forming these little nuclei where they're getting more percentage of their patients off to home. So if we can't change the world immediately ourselves, we can at least contribute to that change by incremental improvements in education. And from my end, that's better fellow education. I think we're doing it our in-center census versus our training PD census is about 2/3, 1/3. So our fellows from the first year are seeing a third of their patients as PD and 2/3 as HD, which is not perfect, but it's better than 90-10.
Thank you.